Hello, thank you for inviting me to speak today. My name is Sarah Ellison and I'm an advanced nurse practitioner and research and effectiveness lead over in Cheshire and Wirral Partnership NHS Trust, working in community services. Today I'm going to be discussing about bridging the gap between specialist care and primary care in congenital heart disease and sharing my own journey as a patient, a nurse and a researcher. And I'd just like to acknowledge the importance of collaboration in putting all of this work together really today, and thank Liverpool John Moores University, One Ellesmere Port Primary Care Network, Cheshire West ICP, that was Liverpool Heart and Chest Hospital and Cheshire and Wirral Partnership Trust. And thanks to Sheila Ross, Find a CHD Collaborative, and obviously Professor Alonso for inviting me to speak today. Thank you. So I've split the presentation into three main parts, and firstly discussing my role as a nurse and a primary care project that I've undertaken, really finding that patients often are not lost, it's just that we've been looking for them in the wrong place. And the objectives of this part are really to raise awareness of the opportunities that we have available to us within primary care and community settings to be able to identify our cohort of congenital heart patients, and also recognise the importance of collaboration and multi-professional working. Then want to discuss my own experiences as a patient and the fact that simple CHD often is very far from simple, and the importance of person-centred care. And finally, my work today as a PhD researcher and how we can prepare our services in the future, especially those in the community, for the growing impact of the care needs of this group of patients that they will have, and recognising their risk factors often occur at far younger ages. So to begin with, my life up until this point, so I was born in 1971 after a healthy pregnancy. I was born at full term, but in 1972, when I was about 18 months old, I was found to have a patent ductus arteriosus, which needed surgical ligation via a full thoracotomy. Back then, these were still quite big operations, and I needed to stay in intensive care, I think, for over a week, and then I was eventually moved to the ward and allowed home. Although the surgery was a success, my parents were told that I would need open heart surgery at a later date because during the operation I'd been found to also have a hole that would need repair. However, this never needed to happen because the murmur that I had resolved, and I was discharged at the age of 5. I had a happy, healthy childhood, played gymnastics, just with occasional chest infections. Into my adult years, I was married, I have 2 children and a career mainly in nursing, and I have studied throughout this time. My main interest has been in the loss to follow-up journey of patients with congenital heart disease and the impact that that can have on themselves as patients and the health services as a whole. So my career has been quite varied. I left school at 16 and originally was a dental surgery assistant, realising quite quickly that actually teeth was not the path for me, and I trained to be a nurse. I qualified in 95 working on acute medical wards mainly, and then moved to critical care units and coronary care units. And it was in 2000 when our National Service Framework for Coronary Heart Disease came out that the opportunity arose for me to specialise within heart failure. And this was a huge opportunity for nurses like myself at the time because it really, cemented cardiology care, and with practical guidelines across the whole of the country that ensured equitable access to services and care and treatment for all patients with cardiovascular problems. And it was whilst I was working within primary care in our general practice surgeries, one of my roles was to create registers of patients with heart failure, and it was during this time that I asked, do we have similar for patients with congenital heart disease? And the answer was no. From this, that has really shaped my career's work in trying to ensure that we have a mechanism in place within primary care to be able to understand our population of congenital heart patients and offer them the same access to the appropriate specialist services that they need as other patients with cardiovascular problems have. I also worked at the university for a while and then became an advanced nurse practitioner and community matron, and it was during this time that I also worked as the North West primary care lead for congenital heart disease, really pushing forward with and promoting the needs of CHD patients and what services we had, specialist services available to us within our Northwest region. I'm currently working as a research and effectiveness lead following on from the COVID pandemic, and my studies for my PhD are within adult congenital heart disease in primary care. So we know that congenital heart disease is one of the most prevalent birth defects that children are born with. A worldwide prevalence is approximately 8.2 per 1,000 live births. But what we're now recognising is the need for lifelong care for all patients with CHD, even those with simple defects. We know have higher risks of adverse cardiovascular events, up to 13 times that of similar age-matched cohorts. And we know also that this group needs, at least the majority of them, will need lifelong specialist access to care in a centre with expertise for adult congenital heart disease. However, despite this, we also know that there is a large proportion that discontinue care for multiple reasons. As many as 62.7% have been discontinued from congenital heart specialist follow-up care at transition ages, and this is a huge percentage. We know that if patients aren't under specialist care, or at least accessing it on a regular basis, the mortality is far greater. And we also now faced with a growing older population of adult congenital heart patients that are increasingly utilising multiple health services far more frequently. And to me, it seems crazy that we're aware of the growing needs of this population of patients, yet we know as many as 50% of them are not having any regular cardiology input, and that's not just from specialists, that's just general cardiology in itself. However, many of these patients will be seeing GPs on a yearly basis, so it makes sense to ensure that we are utilising all of the skills and the opportunities available to us within general practice and primary care to ensure that we have got a collaborative approach to the lifelong care needs of this patient group. If they are actively seeing their general practices at least yearly, it's really important that we ensure that our general practices are supported to be aware of the needs and the risks associated with this patient group and the referral into specialist services should that be needed. But the difficulty that we all face, certainly in primary care, is that there's very little guidance aligning to this patient group has ever been published, and it's a real missed opportunity. So what we did back in 2013 was we did a feasibility study looking at congenital heart disease within primary care, and we were able to demonstrate that through using read codes and disease registers, a list of patients could be created that had a specific disease, so for instance congenital heart disease. And because the numbers are still relatively small, we were then able to look through this list and identify patients that may or may not have become lost to follow-up care. And the mantra of this really was the fact that nearly all of these patients will be registered with a general practitioner, but not all are going to have a cardiologist. And by looking for them in primary care, they can be found. And again, I mentioned we've got diagnostic codes that are attached to each disease, and this can then create the register of patients. Now, when we did this originally in 2013, it was incredibly time consuming. We've now got a much slicker piece of equipment, a data analytics tool that can look at large cohorts of patient data across a wide geographical area, and it not only identifies our patients and our numbers of patients with certain diseases, but it can also risk stratify how frequently they are utilising healthcare resources and what their own individual risks of ill health are. And this is holistically, it's not just looking at the congenital heart disease, it's looking at all of the risk factors that these patients have, and it can create a score for each patient. This then enables us to prioritise our most highest risk patient group. So we took this approach and used this on a primary care network, and we did a case note review. And we were looking, as I say, to identify all of the patients within that cluster of general practice surgeries within a town in the northwest to find how many patients had got a disease code attached to them of congenital heart disease. And we found 412 patients, and we went through all of the case notes for each of those patients. Of these, 83 were removed because they didn't have a definitive congenital heart disease diagnosis, and that left us with 329 patients. And when we're talking about patients that have been lost to follow-up care, I'm not looking at this patient group specifically for those that have got lost to follow-up specialist care with ACHD specialists. It was more looking at them, yes, for had they been lost to ACHD specialist care, but also had they been lost to follow up for investigations, for district general hospital care. It was taking it very much from that patient perspective, or indeed had the patients themselves not attended appointments that had been sent to them. So what we found after looking at this primary care network cluster of patient records was that 7.5% of children and 45.5% of adults had become lost to follow-up cardiology care or investigations or the appropriate ACHD specialist care. For those patients with bicuspid valves, as long as they were under a district general cardiologist and regular echocardiograms and investigations, we didn't class them as becoming lost. On a positive, the ones that were being cared for with the appropriate specialists had really robust care between the specialist centre and the communication to the primary care network. The reason that we had to take out the 83 patients that we found that hadn't got congenital heart disease, some hadn't got a code attached to them that we could recognise as, we couldn't find a congenital heart diagnosis within the records, and others had got renal artery stenosis or arteriovenous malformations, and that's one of the limitations with using read codes, is because they are quite general and they cover vascular disease under congenital heart disease, so obviously that impacted on our results. This hopefully is going to be improved because we are moving across to read codes, going over to what are called SNOMED codes, which will hopefully improve accuracy of coding to ensure that it's only the codes attached to that particular disease group that will be counted in the numbers, as opposed to miscellaneous codes. And what we found, interestingly, was that the top 2% of patients with CHD that we found from the risk stratification tool all actually had simple CHD as their original diagnosis. Now, it may not have been that it was the CHD itself that was causing them to be in the highest risk group, but it certainly was part of the issue. Very often they had multiple other comorbidities as well that were putting them in the highest risk category, in that highest 2%. So the benefits to this project and this audit was the fact that it was proactive rather than reactive. As the numbers were still relatively small compared to other long-term conditions, we were able to identify patients that had been lost to follow-up and be able to signpost them to the most appropriate services. By doing this, it helped raise awareness and knowledge within primary care and the needs of this patient group, and the fact that they were running into problems very often far younger age groups than other patients. And we were also able to highlight what specialist services were available. It enabled clearer advice and referral routes, and hopefully in the future this may help towards reducing inappropriate hospital admissions. And the aim is that it will help support future service planning, and obviously this work enabled collaboration between the ACHD specialists at the local centre, our primary care colleagues, our community nursing service colleagues, and patient representatives themselves. So why patients get lost to follow-up in the first place? Well, it's often multifactorial, and it's not just about the hospital care. There's a whole bunch of reasons, as the literature explains. Patients very often themselves believe that they are cured. They're not aware that ACHD services even exist. Very often, like myself, they could have been discharged from paediatric care. They may well DNA appointments because they feel well, and again, depending on where the appointment is placed or the time of the appointment can impact on whether patients attend. And we know that our biggest concern and cohorts of patients that are most likely to be lost to follow-up are those in the transition age group and our older adults. Professionals themselves often believe that patients with ACHD have been fixed, especially if they've been discharged in childhood, and are unaware that there are specialist services available, and are unaware that often there is this need for lifelong care. If patients do run into problems, often they're referred into district general hospitals rather than specialist centres. So this then frustrates patients and duplicates tests and is a huge cost to resources. We know that transition services do an excellent job, but they are only fairly recent, and the problem is often it's only those with the most complex disease that have that opportunity for full transition pathways. Really, there's a potential need for all CHD patients to have this opportunity. The policies that we've got have huge variations in them. So our international guidelines, you know, there's not a cohesive opinion across all them either. Europe's guidelines still referring very much to an anatomy. America looking more holistically at physiology as well. And here in England, you know, our standards for congenital heart disease, again, were very mainly hospital focused. What we now know, you know, clinical practice for ACHD is largely supported by poor evidence or consensus of opinion. For the second part of this presentation, I wanted just to discuss my own cardiology journey. So as I said, in childhood I had a ligated PDA and then was discharged when I was 5 with no follow-up. I was fine until I got pregnant, and then in 1998 when I did become pregnant, pregnancy itself was okay, but I had a really rough time in delivery. It took me probably about a year to fully recover after the birth of my first child, and I fell pregnant again in 2001, and literally within within weeks of being pregnant I was collapsing. I had got breathless and fatigue and really didn't get to the bottom of what was causing all this. Although I was advised to have no further pregnancies, I was short of breath and would have episodes of pre-syncope. Thankfully had a healthy baby, obviously didn't have any more children, and then had numerous tests. I was passed from pillar to post, eventually getting to see an ACHD specialist, and had an MRI scan where I was found to have a narrowed descending aorta at the PDA site, and I'd got valve regurgitation. But even with that, I still was really breathless and was still having these episodes of pre-syncope, and just felt like I wasn't getting anywhere very quickly at all, really. I was eventually diagnosed with sick sinus syndrome, and sadly an EP study failed to be able to ablate the SVTs that I was having. We'd ended up buying our own handheld heart monitor so that we could capture the episodes of bradycardia that I knew what was happening, but every time a 24-hour tape went on me, nothing would happen. And thankfully when the pacemaker went in, we were able to download, you know, the recordings clearly demonstrating the need for pacing, atrial pacing, and these episodes of SVT, to which I started on bisoprolol. I needed a CPET test because they'd found that I'd got gallstones and needed a cholecystectomy, and the CPET that I had back in 2017 had shown significant deterioration from previously. That was a really rough year because I had the operation, and then a few months later had a TIA, and a few months after that then had chest sepsis. So it was, you know, it was a rough time. So more recently, I've been seen by the exercise physiologist and my ACHD cardiologist, and we've now hopefully come up with a plan. So I'm now on ranolazine for what is like symptoms of HFpEF. My pacemaker is due to be changed in January of 2023. I still get breathless when I'm exerting myself, and because of that I've had to sort of adapt a lot of my life and career to accommodate that, but I stick to an exercise regime religiously, and you know, reluctantly have accepted where I am today with my health condition. But very often we forget that it's not just the patient that is having all these struggles. It's the family that is, you know, caring for these people and looking after them. And I had no clue that my sons felt such weight of responsibility when I was going, you know, poorly with them at home. And they wrote a letter to my doctor, and it says, "Dear doctor, me and my little brother are concerned that our mum's heart problem. We are often at home and she will start to go slow. This worries us as this happens when our dad is away with his work in far countries. Last month he was in China. It's not like he is local. So if something were to happen, we know to phone 999. But what happens next? Think how much we would be worrying. What were to happen if she died? My mum is one of the most important person in my life, so I want to know how to solve this problem before something does happen. Yours sincerely, Joe and James Ellison." So my boys were small when they wrote this. They were about 10 and 7 at the time, and it just goes to show an insight into their world and the worries that they had seeing their mum, me, you know, having episodes where I was pre-syncopal, where I was really breathless, where I was poorly, and the fact that nobody seemed to be able to support me and take it on board, that the impact that this was having, not just on my life, but on my children's, on my husband's, on my friends, on my family. And I think that's something that sometimes we forget, the impact that it has on others, any sort of long-term condition. So from my experience as a patient, I've had the absolute best care, but I've also had some not so good care at times. And, you know, it's really the good, the bad and the ugly. And we talk about illness identity, looking at many different aspects of that. And I think at times I've probably gone through all of those. Certainly when I was being passed from one place to another, pillar to post, I did feel gaslighted at times by the medical profession. I didn't feel believed. The constant was, you know, I was this simple fixed PDA. I think the fact that I was a woman and a cardiac nurse, I don't think it helped. I don't think I fitted into a neat box from like a Stacey Matrix model. I didn't fit into what was familiar, because it was like, well, why should a simple fixed PDA be presenting with all of these problems? Because it was almost not the norm. Yet for me, living in that world, it was an absolute nightmare, because I knew things weren't right, yet nobody seemed to be able to help me. When I had the TIA and the sepsis, I delayed in seeking help because I just almost couldn't bear to put myself through almost the dismissive attitude of health professionals that I'd had previously. So I, you know, as a nurse, I knew things weren't right, but really didn't want to put myself back in that situation. And it almost becomes like chaos and anarchy at this point. I felt engulfed at times because of my condition, but it wasn't because I was worried about my heart. It was the impact that it was having on my life. It was huge, not just myself, but my family and friends. And as I say, it was, you know, at one point I was a community heart failure nurse and I couldn't drive my car because of these arrhythmias. And it was like that in itself was a massive deal. And when the ablation failed, the frustration was immense because I needed to be able to get back to driving, to be able to do my job. And it was almost like nobody understood the impact and the urgency that all of this was having on my day-to-day world. However, throughout all of this, the one person that was there for me and I will be forever grateful for was my GP. They were the sort of anchor in amongst all of this chaos that was going on around me when I was being passed from one place to another. And it was them that probably kept my head above water and will be forever grateful to. I found acceptance because of everything when I saw the exercise physiologist along with my CHD specialist, and after collapsing in a big heap on the treadmill, you know, it was almost like I felt believed at long last. They could see what I'd been trying to say for years and years, and they were able to explain, you know, that this and this are all combining to caused these problems that I was feeling. And I think although anxiety and depression are a huge issue with CHD and any long-term condition, I think too often we're very quick to label people with those things, when actually it's just acknowledging the impact that living with congenital heart disease and other long-term conditions can have on individuals' life day to day and their families. And sometimes all you need is that acknowledgement and being listened to, and somebody being able to put the pieces of the jigsaw together. I know this can't be magically fixed, but I feel a whole heap better knowing that people are believing what I've been saying to them, if that makes sense. So I've had to change my career path to accommodate my current, health needs, and I'm, touch wood, doing really well at the moment. And I've hopefully tried to turn my own lived experience into a positive and try and improve future care for patients with CHD. And hopefully by doing the work with my PhD, that will be able to add some evidence and more research to the growing body of knowledge that we're now getting. So the final part of my presentation is about the research that I'm undertaking, and I looked at this across the whole of Cheshire, in a county in the northwest of England opposite Liverpool. And what we were able to do using the big data analytics tool that we have now got access to, we were able to find our population of patients that were registered with a general practitioner within Cheshire that had a sharing agreement in place as of July 2022. And what we found was that our population was about 765,500, and of that we had 6,419 people with a disease code of congenital heart disease. And of that group we classed children as 0 to 19 because of the way the data analytics tool works. So unsurprisingly, we found that we had more adults than children with congenital heart disease, and for the purpose of these slides it's the blue bars that are representative of CHD patients. But we did actually find that we had quite high proportions of children with a CHD diagnosis. Now there's multiple factors for this, but whether it is because of better investigations, better reporting, better coding, I'm not sure, and this is certainly something that we need to look at more so in the future. What we also looked at was our disease prevalence across patients with and without congenital heart disease, and what we found was that the top two conditions that our population had were anxiety and depression and hypertension, with the CHD cohort ever slightly having a slightly higher risk of anxiety and depression than our non-CHD cohort. Interestingly, with hypertension, again, this is one of the additional comorbidities that we are now finding that these group of patients are having. We looked at cancer, asthma, diabetes, as well as, again, these are quite highly prevalent disease groups. And interestingly, with the asthma group, there was a slight increase in our CHD population, and again, this could be due to multiple factors. But the most notable results were those with the cardiovascular disease, and for atrial fibrillation and atrial flutter, stroke, TIA and heart failure, very notable increases in prevalence for these disease groups for patients with CHD compared to those without. We then looked at breaking this population down into age groups, and we found, as I say, with anxiety and depression, slightly higher incidence with our CHD population, and similarly findings of previous studies, the cohort that had the greatest risk of anxiety and depression were those in the middle age range groups. With arrhythmias and certainly atrial fibrillation and atrial flutter, this is what this graph shows. Again, can see quite notable increase in prevalence for our younger population group of CHD patients, and quite notably higher risks of running into arrhythmias than our non-CHD cohort, again at much younger ages. and likewise the same for stroke and TIA. Those patients with CHD, again, running into problems with this at very often much younger age groups and at far greater prevalence. So from a thoughts and considerations perspective, really, I truly believe that general practice surgeries really would benefit from having congenital heart disease registers like we have for heart failure patients and other long-term disease groups. The numbers are still small, and we can find the patients that have been lost to follow-up through hand searches. Our primary care and community colleagues are experts in lifelong care, in cradle to the grave care and comorbidity care, so it's a real opportunity to understand and gain insight into their expertise that can help ourselves from a cardiology perspective in caring for this patient group. By learning and supporting each other and the collaborative approach, it can really help benefit all of us, including, most importantly, the patients in the future. Potentially looking at hybrid ACHD clinics and models for current and future cardiac services for surveillance and support, and the real importance of clear communication from hospital care back to primary care can't be underestimated. It has got to be really clear, with very clear instructions on referral routes back into care should these patients need it. Should we ever be discharging children? I'm just putting that out there because it does make you wonder, given the problems that we know that this group can run into in adulthood. And there's a real need to recognise and remember that we have got a growing population of older adults that have had very little studies done, or, you know, have been recognised as this growing group of patients that are needing multiple specialties to be able to support them into older age. And again, it's not just cardiac comorbidities that they're running into problems with, it's others as well. Again, raising awareness of the long-term impacts of CHD and identify learning needs so that we can, as I say, learn from each other. Recognising that with our ACHD patients, they can run into problems at much younger ages. So for instance, like myself, simple, supposedly fixed PDA, now have tachybrady syndrome and had a TIA. Not in any way did that come up as a risk factor on any, you know, looking at likes of Chad's VASC scores, stroke scoring, clinical systems. You know, everything is tailored to older adults in the, you know, 60 to 65 age groups, but yet we're demonstrating that our CHD population are running into these problems in their 20s, 30s and 40s. So again, you know, there's more research needed in these areas. We really need to remember what's important for our patients and asking them what matters to them. Person-centred and family-centred holistic care, vital. And accept that we don't have all the answers, and ensuring that we're doing proactive care rather than reactive, and empowering the patients. We need to ensure that our patients are part of this journey from day one, and that, you know, they have got a responsibility to help support their own health and well-being. Engaging patient groups, utilising our other cardiac services that we've got, not just in hospital settings. You know, we've got community cardiac rehabilitation. The exercise physiologists were an absolute godsend to me. Psychology, network learning, all of these opportunities that we have, community-based, you know, specialist nurses, pharmacists, and our colleagues in district general hospitals. It's really trying to work together for the benefit of these patients. So, future considerations, registers within primary care and the data analytics tools can help support that, understanding our population and our future service provision that's needed, collaboration and shared care models, and utilising all the resources we have available, because there is a lot of us that are growing as a population of patients, and there are too few ACHD specialists to be able to cope with the demands placed upon them. Again, person-centred care, what matters to you? When was the last time any of us asked our patients that? And it's a really important question. Nobody, I don't think, has ever actually asked me that in my 51 years of needing healthcare. And actually, very often the answer you get may be very different from the one that you're expecting. and remembering that even simple supposed repaired ACHD patients can face significant problems in the future, and the risk factors occurring at far younger age groups. And a clear communication between all services and working in partnership with primary care is really important. So to finalise this presentation now, thank you to all of you, past, present and future, for all you've done for patients like myself. Let's keep learning and working collaboratively with our patients and our wider colleagues to enable all of those with congenital heart disease to lead their best lives. If there are any questions or you want to contact me, please don't hesitate to do so, and these are my contact details here. Thank you very much.